Dear professors, dear colleagues and students, let's begin the opening ceremony. And the floor is given to Rector of Tashkent State Dental Institute, Professor Nadir Khaydarov. Professor Nadir Khaydarov, you are welcome.
Уважаемые коллеги, дорогие друзья, я очень рад приветствовать вас на сегодняшней конференции. Сегодня во всех странах мира наблюдается тенденция к увеличению заболеваемости и смертности от рака груди. Высокий уровень смертности в первую очередь связан с поздним лечением пациентов, отсутствием эффективных программ и скрининга и низким уровнем диагностики и лечения рака. Основная цель конференции – собрать людей из всех слоев общества для разработки мультинаучных стратегий для эффективной диагностики и лечения рака груди, а также улучшения здоровья женщин. Я хотел бы выразить свою глубокую признательность профессорам и докладчикам, которые являются лидерами своей области. Мы приложим все усилия, чтобы сделать нашу конференцию информативной и платформой. И надеемся, что конференция станет полезным опытом как для докладчиков, так и для участников. Благодарю.
Dear colleagues, I am very pleased to welcome you to today's event. Today, even in both developed and developing countries of the world, there is a tendency to increase the incidence and deaths of breast cancer. The high mortality rate is primarily due to the late treatment of patients, the lack of effective screening programs, and low level of diagnosis and treatment of cancer. The main aim of the conference to gather people from all walks of life to come up with the multi-scientific strategies to effectively diagnose and treatment breast cancer and to promote women's health. I would like to express my deep appreciation to Dr. Abhijit Chakraborty from Baylor College of London, Dr. Nazgul Amarbayev from Kazakhstan Cancer Institute, Dr. Ayman Ali Hasan AbouShmeila from Damanhour Oncology Center, Dr. Danko Konstantinov from UK, and Dr. Rania Azmi from Fadia Survive and Thrive Association. We will make all our efforts to make our conference remarkably informative and fruitful, and hoping that the conference will be a rewarding experience for both presenters and attendees. Thank you for your attention. Thank you, Professor Khaydarov. Now the head of Oncology and Medical Radiology Department of Tashkent State Tashkent State Dental Institute, the General Secretary of Oncology Association of Uzbekistan, will come out with welcoming speech. Professor Jamila Polatova, you are welcome.
Dear colleagues, we thank all of you for taking the time out of your busy schedules to participate in International Breast Cancer Conference. It is my pleasure to start our department activity from organization conference dedicated to such an important problem of as breast cancer. We have chosen the title of the conference, Multidisciplinary Approach in Breast Cancer, from the basics through clinics to patients advocacy, because only multidisciplinary team can gain better treatment results. This conference aims to draw together scientists, researchers, healthcare providers, advocacy group, and medical students to increase awareness of breast cancer, enhance a better understanding of the disease and its medical treatment, and improve the quality of life of breast cancer patients. I would like to give thanks to all the speakers for preparing high-level and state-of-art topics for our today's event. Today, two memorandums also will be signed, which put the first brick to the future cooperation between our countries and organizations. I wish all the participants to have a good time. Thank you.
Thank you, Professor Polatova. I give the floor to Dr. Ayman Ali Hasan AbouShmeila from Egypt, who works as a chief of surgical oncology at Damanhour Oncology Center, Ministry of Health, section of specialized centers, head of the training department and Damanhour Oncology Center. Please, Dr. Ayman.
Hello, everybody. I'm very pleased to be with you today. First, I would like to thank my friend Professor Ali Sher for his invitation to join you today through this scientific conference. Also, I would like to express my appreciation to the Tashkent State Dental Institute and to Professor Khaydarov and Professor Polatova. It's my pleasure to welcome all the participants today for this scientific webinar, and I welcome all the eminent speakers and guests. It is somewhat early here in Egypt, and I think it is more early in UK, and it is almost midnight in USA, but I am sure that everyone is happy to share his knowledge and experience breast cancer management. This year, I think COVID-19 pandemic has changed dramatically the educational dynamics and the way of learning and exchange of experience. Despite its impact on the social and scientific events, it actually led to more webinars and online conference. So a positive point for the COVID. I think there will be plenty of knowledge which will cover all the issues about breast cancer today, and I hope this conference would be help all of us to adopt the up-to-date practice for the management of breast cancer. Wishing a successful conference and thank you.
Thank you, Professor AbouShmeila. Now I give the floor to Rania Azmi. Dr. Rania Azmi is a cancer patients empowerment and research advocate, co-founder and president of Fadia Survive and Thrive Association, supporting and advocating from cancer patients' quality of life and raising awareness for prevention, member of the UICC and the Advanced Breast Cancer Global Alliance, common advocate in science, AIC Training Task Force member and vice chair and member of research funding committees, Kuwait and Egypt. Dr. Rania, you are welcome.
Thank you so much, Dr. Alishar. And I would like first to welcome everyone and thank you for having me at the Tashkent State Dental Institute, like the Oncology and Medical Radiology Department. I know that many colleagues and participants from around the world are watching you now, so good morning to the ones that is morning for them, and really good evening for the ones that it's late evening for them if you are joining from the States. And I know some of you are. I'm very thrilled with participating with your international conference. Really thank you for each and everyone at Tashkent State Dental Institute and the Oncology Department specifically. It cannot be more timely to really sit together, even if it's virtually, to address the issues of interest and importance for cancer patients. Let's remember that we are all here because of the cancer patients. I am more leaning toward the patient advocates. I know you're doing your utmost as oncologists and all stakeholders in cancer, but it's extremely important to sit together and find out practical ways to prolong life, improving quality of life, and also find an end to this never-ending battle or war with cancer. So thank you, and I'm very thrilled also that this will not be an ad hoc or one-time event of collaboration between us. I'm very thrilled to sign with you the Memorandum of Understanding between Fadia Survive and Thrive and Tashkent State Dental Institute, the Oncology Department. Thank you. Rahmat.
Thank you, Dr. Rania Azmi. Now the Memorandum of Cooperation signing ceremony will begin. Joint activities within the framework of the Memorandum of Cooperation will be implemented in the following forms: information exchange, exchange of specialists, doctoral students, graduate students, faculty, joint scientific researchers and organization of scientific conferences, seminars, and symposiums. The first one will be with the Damanhour Oncology Center.
Already, we signed. Do you see here the memorandum? This is the memorandum between Tashkent State Dental Institute and Damanhour Oncology Center, and it's already signed by our General Manager, Professor Ragab Sharif, and we are glad to share and participate in this memorandum and to have further cooperation between our institute and yours.
Let me congratulate both parts and wish fruitful cooperation in the future. Please proceed the signature ceremony. Let's move to the second memorandum of mutual cooperation with Fadia Survive and Thrive Association, represented by Dr. Rania Azmi.
Sure.
The main aim of activity of Fadia Survive and Thrive Association revolve around cancer patient advocacy, cancer prevention, control, and elevating its side effects by improving patient quality of life via evidence-based knowledge being put into action. Please proceed the signature procedure.
Thank you. And I already signed.
Let me congratulate both parts and wish fruitful cooperation in the future.
Thank you. Thank you, everyone. Looking forward to our collaboration indeed.
Thank you. Okay, we can move to the main part of the conference. Before starting the main part of our conference, I should tell that the audience can write down their questions into the chat and speakers can answer them at the end of the conference. Now we can move to the main part of our conference, and let me introduce Dr. Abhijit Chakraborty, very smart and perspective basic scientist, research associate PhD, Immunology, Allergy and Rheumatology Section, Baylor College of Medicine, Houston, Texas, USA. His presentation is dedicated to molecular biology of breast cancer. Dr. Chakraborty, you can start your presentation.
Yeah, thank you. Thank you, the organizer, Tashkent State Dental Institute and the Oncology Medical Radiology Department, and especially my friend Alisa. So I'm honored to be present over here. So today's my topic of discussion is the molecular basis of breast cancer prevention and treatment strategy. So as we know, the breast cancer is the malignancy of tumor that start from the cells of breast tissue. Actually, this malignancy happen in the two places. When you start from the duct, it's called ductal carcinoma. When you start from the lobule, it's called lobular carcinoma. There are many risk factors that associated with the development of the disease. Some of them we can modify, some of them we cannot. The risk factor which we cannot modify, that's including increasing of age, female gender, menstrual factors, early age at menarche, old age at menopause, null purity, family history, genetic predisposition, etc. And the risk factor which in our hand, which we can control, that is the reproductive factor, age at first labor, parity, lack of breastfeeding, obesity, alcohol consumption, tobacco smoking, etc. There are few histological factors also included, that is the proliferative breast disease and lobular carcinoma in situ. So the breast cancer mainly divided into two parts. One is the sporadic cancer, one is the germline cancer. The sporadic cancer is a cancer which single occurrence of cancer in a family, but when there is a multiple family member infected with the cancer is called germline cancer. This germline cancer divided into two parts also, hereditary and familial cancer. The familial cancer cause a cluster of cancer within a family, but it should be late onset. But in case of hereditary, the cancer which multiple affected individual present in the same generation, or it should be early on stage. So in case of germline cancer, it means a mutated gene which you carry and born with that genes. That does not mean it can be developed disease. It can be passed on to the relatives and increase the risks to develop breast cancer in future. But somatic means it can cause by somatically. It cannot pass to the relatives or any other, and it cannot be tested as a part of this. It can be tested as a part of decision-making therapy for cancer. So the common mutations in the genes of familial breast cancer, most important is the BRCA1 and BRCA2 genes. These are the most predisposition mutation that develop breast cancer in early onset of age. And other mutations like P53 gene, P10 gene, ATM gene, that's also involved, but these are the rare and low moderate risk factors. So in the progression of breast cancer, in the first case, when the predisposition genetic risks happen, the BRCA1 and BRCA2 mutation affecting the DNA repair. In case of hyperplasia, there are some estrogen and progesterone hormonal receptor that regulates the cell cycle and suppress the apoptosis of cells. These are involved. In carcinoma in situ, there are different kind of other mutations which is not germline, that are involved. And in case of metastatic breast cancer, the mutation of BRCA1 and BRCA2 is and other genes which resulting the defect of mismatch repair of DNA. So if anyone have the BRCA1 or 2 gene mutation that they predispose the breast cancer, their chance to develop the disease increases to 55 to 85%. So how does it happen? So previously we believe that these BRCA genes resulted from Knudsen two-hit model of carcinogenesis. That means if anyone have one gene mutated and in some other circumstances like environmental factor or hormonal factor, another gene going to mutate, then they develop the disease. But nowadays that that model is rejected, and now people believe in the Nilsal and Ballstein caretaker gene model. So that model described that mutation in BRCA1 gene only predispose for cancer development, but the loss of this gene correlate with the loss of BRCA function are necessary for development of cancer. So the mutation are different kind of single nucleotide polymorphism happen over there. That is very common. But in case of rare variant, there are different mutation happen in the CHEK2 and ATM gene. And most importantly, rare variants which is high moderate to develop disease is BRCA1, BRCA2, and TP53. So what is the breast cancer hereditary? So hereditary breast cancer means it's occur in multiple generation. It should be in younger age onset, often less than 50 years of age. Bilateral cancer or multiple myeloma is common. Family history of unique tumor combinations like sarcoma, breast, or brain in same family, or male breast cancer or ovarian breast cancer, and breast, thyroid, or uterine cancer. So this hereditary breast cancer, we know only 50% of the cause of this disease development, and rather 50% is still unknown. Among this 50%, only 15% is responsible for BRCA1 and BRCA2 gene mutation. So the main role of these two gene, predisposition gene, is to repair the DNA damage. So if anyone have that breast cancer, they have chances to have the BRCA1 or 2 mutation. They are just prone to develop disease 50 to 85%. They're also prone to develop a secondary primary breast cancer as well as the ovarian cancer. So there are different studies available where they estimated the risk factor of BRCA1 carrier significantly varies That means if patient have any of these mutation of these genes, the patient highly develop disease before age of 32 until later of age. So there is some factor which contributed for that hereditary breast cancer in case of developing countries. So that is the most unknown part for the developed countries and most challenging things. That is the relative contribution of breast cancer of these genes is still unknown for different developing countries. So what are the common mutation over there? What are the role of polymorphism onset progression and therapies there? And role of screening, cultural sensitivity is not still unknown, and economic priorities are there. Global collaboration in molecular epidemiology. That's we need to fill up to become grown in this section of breast cancer in developing countries. So who should be considered for testing then? So the patient who have breast cancer before age of 45, the patient who have ovarian cancer cases, particularly high grade, the male breast cancer patients, breast and ovarian cancer in a single lineage, 2 or more women with breast cancer less than 50 years of age, Ashkenazi with breast or ovarian cancer. This is a particular community. And breast cancer, a patient with breast cancer less than 60 years of age, and that happened in the triple negative manner, and bilateral breast cancer, which consider up before 60 years of age. So also the most important thing, we need to pay attention to the pancreatic cancer and high grade of prostate cancer. And the Ashkenazi individuals is most important to prone BRCA1 and BRCA2 gene mutation, and all women at age 30 and who are related with many other issues like small tumor or painless tumor in the breast, they should be tested for this BRCA1 and BRCA2 germline mutations. So let's say one 35 years old woman comes to family planning visit, and you incur a family health history and find out that that patient have maternal family history is negative for cancer, but in paternal family history significantly involved in the breast cancer or other type of cancer like paternal aunt with ovarian cancer of age at 55 and paternal grandmother with breast cancer age of 42. So what you will do over there? You should go for the BRCA1 and BRCA2 genetic testing. In other case, if you see some patient with less than or 40 years old woman who asks to breast cancer genetic test, and you find that their family history contain mother with breast cancer at age of 58, maternal aunt with breast cancer at age of 65, and paternal grandfather with breast cancer with age of 79. It should go with the breast cancer genetic diagnosis first before starting the treatment. So what is the genetic testing? What you do after that? So if you got the positive result for BRCA1 and BRCA2 testing, then consider this testing to the other family member to get them routine checkup and to prevent the developing disease in future. If you get result not confirmed, there should be some other associated risks or other associated mutation which related to the breast cancer that need to check. If you get the negative, it's the most that's emphasized risks, the unidentified familial mutations. So these are the treatments available for the BRCA1 and BRCA2 related disease breast cancer, that is oliparib, veliparib, rucaparib, icaparib, and BMN 673. So oliparib is the most common monotherapy in patient with advanced cancer and also germline mutation of BRCA1 and 2. So what does oliparib does is a inhibitor of PARP poly-ADP ribose polymerase enzyme. That enzyme help to repair this double-stranded break. So when oliparib is come and block this PARP, which cannot be repaired this gene, DNA double stranded, red cells undergo the cell death. So the tumor cells which have that single stranded break, oligonucleotide block that part, and the tumor cell going to undergo to cell death. But in that case, when BRCA mutated cell is there, it's already go to the cell death. Linparza, approved by the US Food and Drug Administrator in 2014 to treatment of breast cancer, also ovarian cancer patient with germline BRCA1 and 2 mutation. So there are many sites available in the website, so you can check what gene are involved in the breast cancer susceptibility. So if a patient come to the clinic, you've got some family history involved with there, so you need to check lots of gene mutations. So how they are checking till now? So till now, if one patient comes for the checkup or treatment, you need to access the patient, test for some known gene, and you got the negative result, then you again test for other known gene, and it's running by cycle. But nowadays, that approach improved. So you access the patient, cell multiple gene paneling, disclose the result then. So what is the multiple gene paneling? So there is lots of kind of gene, like near about 100 different kind of genes which are responsible for breast cancer. You just go through that panel and check what genes are involved in the particular breast cancer case, and you can then decide the treatment strategy according to the mutation or gene analysis. Why we can do this one? So this is more cost effective for testing, and you can do multiple gene at a time and serial testing. You don't need to wait for the one test report and then go for the next one. Molecular pathway behind the cancer progression can be well understand if you have that results. And the same cancer can be seen with different gene mutations, so that you can decide which particular therapy you can use to treat the patients. So the most important issues of this stage is high penetration and moderate penetrate genes are on the same panel. So you cannot differentiate that one. So if sometimes it's happened, you cannot recognize the specific syndrome of this disease. And other tests you will do on this test, and so you need to focus on for the treatment you need to do the other test also. But the clinical utility is the most. You can do risk assessment, value of true negative, right? So like if any test give you a false negative or true false positive result, you can understand with this paneling testing. The risks of breast as well as other cancer, secondary primary cancer, you can understand, and risks of other cancer which is responsible for the BRCA1 and 2 mutation, you can understand that one. You can take care of that part also. The prognosis might be you can impact administration of adjuvant therapy, so you can understand what's going on behind the cancer development. So you can then think about the adjuvant therapy, what therapy you should use for that one, and this one also can use for drug development. So this is our study. We found also that when BRCA mutation is present, so the few are the most important factor is the age and the premenopause, early stage of menopause, or and PR prognostic receptor, as well as the triple negative breast cancer. These are the most important factor that cause the BRCA1 mutation. So if anyone have the BRCA mutation or any BRCA1 or 2 mutation, the overall survival rate going down, and also the disease-free survival rate also going down if anyone containing the BRCA mutation and they develop the disease in future. So in case of triple negative breast cancer, the triple negative breast cancer who contain the BRCA mutation, that their lifetime, their survival rate is very low compared to the triple negative breast cancer who don't have any kind of BRCA1 mutation. So in many developing countries, the cost is the main issue to get this testing, genetic testing for the breast cancer. So for that one, like for our experiment, we use the immunohistochemistry as an additional method for selection of patient. Which patient should we give for the genetic screening or not? So if you check with the BRCA1 antibody by immunohistochemistry, if you get some positive value over there, then you can consider this patient should go for the genetic testing further. If you get that negative result in the immunohistochemistry, you can be considered it's not to go for the genetic testing further. So this test has a high sensitivity and high specificity. Also is you can understand the known risk factor, which mutation is that mutation is susceptible or for the patient or not. So consider cancer genetic counseling refer if the myriad table indicates the significant risks for the BRCA1 and 2 mutation. Myriad table means there is a myriad genetics. They give some indications and some advice how to detect the high risk factor families. If you find any family medical history suspicious for hereditary cancer syndrome, that patient should be go under the genetic counseling and genetic testing. Some client extremely anxiety about the cancer family history. The client has questioned beyond the scope of your practice. So who are in high genetic risks? The 2 first degree or 1 first degree and 1 second degree relative in the same breast cancer patient, 3 or more family member of first degree or second degree patient with breast cancer by any age, the patient with male breast cancer that should go this testing, patient with first degree relative with breast cancer less than 40 years of age, 2 or more cases of ovarian cancer in same lineage, and Ashkenazi Jewish, that community, and any family history of breast cancer less than 50 years of age should undergo with this testing. And some of them who have both breast and ovarian cancer. So there is some recent advice and from the American Society that genomic testing is minimize the chemotherapy exposure. That means for many years, whatever the breast cancer patient, all give the chemotherapy, all treated with the chemotherapy. But after 2018, a study published in New England Journal of Medicine, they showed that more than 85% patient over age of 50 whose breast cancer was HER2 positive or HER2 negative and no and had not spread of any lymph node, they are not getting any they are not getting any help with the chemotherapy. So in that study, the genomic assay that look that expression of different gene in this patient primary tumor, the tumor gene expression pattern shows whether it's responsive of the chemotherapy or whether the endocrine therapy alone, and which could be better choice. So that the Oncotype DX test can be considered for the testing for patient which have the BRCA mutation or not. And the number of genetic mutation like BRCA1 and 2 already known mutation in different person risk development, but there is some other mutation also available right now that can be considered as a highly hereditary breast cancer. So next generation sequencing technique is helping for this portion to identify other hereditary cancer syndrome of the people at high risk. Liquid biopsies nowadays are highly considerable. The liquid biopsy is circulating tumor cells and cancer cells. These cells are break away and from the tumor in the blood vessels. The circulating tumor DNA is the DNA that released from that cancer cells in the blood. So nowadays researchers are investigating that and test that DNA, circulating tumor DNA, to identify whether the cancer go to the metastatics already or not, starting to grow or not. So this is called liquid biopsy. So this is easier and much less expensive than traditional needle biopsy. And triple negative breast cancer should not be treated with hormonal therapy and should be undergo with the genetic testing first and then treat. And most recently, the new advanced technique which can be considered is single-cell ataxic sequencing analysis. So that's analysis, you can know millions of RNA in particular breast tissue cells, breast cells, which is responsible to develop the disease. So you can identify some particular RNAs which are responsible, you can treat by this way. But this techniques is still under develop right now in the research stage. It's not in marketing stage right now. So here, another gene that is called timeless is circadian regulator. These genes nowadays is researcher proved that this is help to develop the breast cancer and have a very poor diagnosis prognosis. So these are the results of tissues from the patients who have survival less than 5 years, and these are the tissues from patients who survive more than 5 years after breast mastectomy. So here the timeless protein expression is very high compared to this one, and their survival rate also very low. So this timeless gene could be a future prognostic marker for the breast cancer and could be a future targeted therapy for the breast cancer. This timeless gene is tested in the mice level for mammary gland formation. So when the timeless gene is present in the mice, the mammary gland and breast tumor formation occurred very high, and when the gene was knocked down, the breast tumor going down. So this all are the proof that timeless could be a future targeted therapy of gene. So now from now you can go and you can consider for the genetic testing as it's a very useful for the patient and their family member, both to prevent and to treat cancer. Genetic testing is continuously evolving. BRCA1 and BRCA2 mutation are the most commonly found, and we have reasonable others resource how to manage it. So a new genetic testing need to perform to clear knowledge in terms of how the chance to prevent how the chances and how the cancer could be cared and improve the patient outcome. Variants of unknown significance should not be managed as mutations. In face of rising polyphyletic mastectomies, we need to emphasize to the patient of what this kind of mutation this kind of disease from the different, how they are different from BRCA1 and 2. So this by this you can consider which patient go for the genetic testing and how to treat that BRCA1 to related breast cancer. That's all for today. Thank you.
Dr. Chakraborty, thank you for your very informative presentation. During the past 2 decades, the significant progress in understanding of breast cancer nature has been noticed. Nowadays, breast cancer is known as heterogeneous disease, which includes malignant tumor with different clinical courses, response to treatment, and prognosis. With the development of fundamental oncology, many biological markers are being discovered that allow personalized the approach to treatment choice. We can start the second presentation of understanding scientific from Kazakhstan Cancer Center, Dr. Nazgul Amarbayeva. She will speak about impact of germline mutations in breast cancer prognosis. Let's begin.
Hello, dear colleagues. Thank you, Alisher, for inviting me in such important conference. Greetings from Almaty. I would like to share with you the results of our research concerning germline mutation of in breast cancer in Kazakh population. Today we talk about impact of germline mutations in breast cancer prognosis. My name is Omarbayeva Nazgul. I work in a breast cancer center as a breast surgeon in Kazakh Institute of Oncology and Radiology in Almaty. So if we look for the statistics, cancer incidence and mortality in Kazakhstan, the leading place belong to breast cancer, lung cancer, and gastric cancer in both gens. Population of Kazakhstan is 18 million 400, and cancer prevalence is 179,000. About the age structure, as we see in the table on the right side, we see that 70% of cancer patients are working age population. 5-year survival in breast cancer comparing to OECD countries, in the economical development countries. 5-year survival in OECD countries 89%. In Kazakhstan, it's 62%. This slide is close to the slides of Dr. Apouchi. Here we present the risk model of risk factors of breast cancer, moderate risk and high risk. To the moderate risk of breast cancer, we the effects of first-degree relatives and the relative risk grows to 1.4 to 3. So if there is 2 and more, the relative risk increases in 5. The one relative at the age of less than 40 years, it increased relative risk of breast cancer in 2.8. So the biopsies also increase the risk of breast cancer, especially atypical hyperplasia, increase relative risk 4 times. As well as hormone replacement therapy for 5 years increases the relative risk of breast cancer 2 twice. And then for the high risk, there's age. Aging is 70 to 74 age. Comparing to young age, it increased the risk 56 times. BRCA1 and BRCA2 mutations increase the relative risk 24 and 12. Chest radiation, contralateral breast cancer, Western countries, and the mammography density with 45% also is belong to high risk of breast cancer. So there is other additional candidate genes that increase the risk of developing breast cancer. Spectrum of mutation varies greatly between countries, and the ethnicity which necessitates the search mutation with the diagnostic significance in each local population. So there is a list of additional genes which can increase the relative risk of breast cancer. The ATM, BART1, BRIC1, CHEK2, NBN, ALK2, and RAD51C and D is the additional breast cancer risk. In our center, we in 2017 we started the trial, the research, which which contain the breast cancer patients. So, according to the results of the studies carried out in the Republic of Kazakhstan, it's unknown that unlike other populations with a relatively high frequency of mutation in the BRCA1 and 2 genes, so knowledge of ethnic characteristics of the spectrum of mutation will make it possible to introduce DNA diagnostics to identify a group of high-risk developing breast cancer in Kazakhstan. So before this study, we didn't know any information about the genetic portrait of the DNA portrait of the patient of breast cancer. So the Minister of Health of our country financed the targeted program funding for genetic analysis of patients with breast cancer and colorectal cancer. So, purpose of the study was identify hereditary mutations in patients with breast cancer to develop an algorithm for genetic testing women at high risk. So, the study contained the main group, 235 women, the control group of 50 women. The woman was age of less than 40, only young ladies. Female patients with breast cancer verified histologically in any stage and subtype, and they were Kazakh ethnicity. The control group was the condition of healthy person with the urgent history, without a urgent history of breast cancer. So average age was 34-25. Breast cancer type was the most, it was a nodule type. The 7% had the infiltrative breast cancer, 4.5% is ulcer, and 4% was the Paget disease. In the clinical features, we saw that by the end of the study, we had 4% of deaths, 16.2% of progression, 41% in remission virus, and 38% in treatment during the trial. So the subtype of the tumor was in 12 and 6% luminal A, 20 and 7 is luminal B, HER2 negative, and 15.6% of HER2, luminal B, HER2 positive. HER2 enriched group was 9.6%, and the triple negative subtype was in 41.4%. So in this pie chart, we can see that almost half of patients were triple negative. By the staging, mostly it was 56.6% showed the second stage, 27 and 7 was the third stage. First stage was only 9.6%, and 6% showed the fourth stage. We can, from this pie chart, say that as the patients are very young, the tumor growth is very high and were differentiated. By the materials on the basis of voluntary informed consent, when verified diagnosis samples of peripheral blood from breast cancer patients were collected, and DNA was isolated, libraries were prepared, and the massive parallel sequencing, next generation sequencing was performed on the massive Illumina platform using the TrueSight cancer kit. Includes 94 genes with a predisposition to cancer and 287 CNVs associated with the development of cancer. We used the 94 gene panel, was a long, high risk of developing cancer. Informational analysis of NGS data was processed by the standard NGS programs, the alignment and variant detection, and then it was the annotation and filtering, interpretation, and in the end, the genetics give us the report study. So population database for estimating the frequency of variants, we use three big database: Exome Aggregation Consortium, Exome Variant Server, and the 1000 Genome Project. This is a very big database where all the research from all over the world picks the new mutations from patients. So in our study, we saw that in 235 patients, there were 29 and 3% showed the pathogenic mutations. The variants of uncertain significance showed this 70. Mostly it was the missense mutations, and 2% showed the deletion. So in our population, there is also high incidence of BRCA1. It was 9.6%, BRCA2 7.6%, and less it's at 3, PALP2, MSH6, JET2, and another mutations in another gene. So in this slide, we see that so we divide into groups: BRCA1 and 2 mutations and BRCA negative. BRCA1 and 2 group, we see high amount of deletion, insertion. It means that the mutations, pathogenic mutations, were very severe, like frameshift mutations, compared to non-BRCA. See the distribution of spectrum of common mutations among breast cancer patients. We see the BRCA mutations are mostly 329 and duplication and deletion. So mostly it's the mutation was a mutation which is very popular among the world. So here we show the 8 mutations identified that like novel mutation, because there were no information. They almost all are frameshift, which is very severe pathogenic mutations. They are all were novel, and world database, and mutations were novel. So by the counting of the correlation between disease progression, we see the correlation between the subtypes and disease progression or remission. So here we can see that there is a high correlation between disease progression in a group of patients with the BRCA mutations and comparing to without no pathogenic mutation. 20 so in the second table, we see that triple negative breast cancer has a very strong correlation between one and comparing to the group patients without. So almost half of the 50.3% of patients were with the triple negative breast cancer had BRCA1. So, according to the 5-year survival, the can see that comparing to the all group, shows the 5-year survival 82.8%. In the group, the polygenic mutation, 5-year survival was 7.5%. So according to this study, we are nowadays creating new approaches to prevention and screening of mutation carriers. So there is the mutation genes which needs screening and prevention activities. So for each mutation, for each genes, we tried to make guidelines, like recommendations on screening and prevention. Nowadays, it's just recommendation character, but in the future we will make national guidelines for the. So my acknowledgement is the project manager in Khaydarov breast cancer department, where we collected the patients, now Institute of General Genetics and Cytology.
Thank you, Dr. Nazgula Marbaeva. Let's me move to the next lecture, Dr. Ayman Ali Hasan AbouShmeila. As I told you, he is Chief of Surgical Oncology Department and Damanhour Oncology Center. Dear Professor, you are welcome.
Thank you. I'm honored to present to you my talk about change of concepts in breast surgery. My name is Ayman AbouShmeila. I'm consultant of surgical oncology at the Damanhour Oncology Center from Egypt. As we all know, one of the main measures of successful breast cancer surgery is local control. It has been demonstrated that under-treatment followed by local failure is deleterious in some subgroups of patients. This knowledge had led to a shift in the treatment strategy of patients with breast cancer. Starting from the Halsted radical operation described in 1894 and remained the operation of choice for many years, passing by the modified radical mastectomy described by Patty in 1930, and then the era of quadrantectomy and lumpectomy, reaching to the era of oncoplastic breast surgery described first by Odrich in 1994. This shift in the treatment strategy of patients with breast cancer was influenced by the fact that therapeutic equivalence of less extensive surgery was demonstrated in a prospective manner through a number of specific trials, beginning with the landmark National Surgical Adjuvant Breast and Bowel Project, the P4 trial, followed by 6 major trials which were initiated in North America and Europe to investigate breast conservation therapy. With up to 20 years of published follow-up data for these trials, breast conservative therapy has been demonstrated to be an acceptable alternative to mastectomy with similar survival outcomes. So what we have the new data about the margins needed. When considering the best margin widths, it is useful to remember that a negative margin of any width doesn't indicate the absence of residual unresected tumor in the breast. It simply suggests that the residual tumor burden is probably enough to be controlled with radiotherapy. Even in cases with mastectomy, which provides the largest margin that can be obtained, doesn't eliminate local recurrence. So this indicates that residual disease burden is not the sole determinant of local control, but nowadays we all realize that the local recurrence is related more to the underlying tumor biology and to the availability of effective adjuvant therapy. In a Danish cohort, over 16,000 patients were treated with wide local excision and post-operative radiotherapy with a 5 to 10 years follow-up. And the objective of the study is to answer the question, is wide margins are better? Actually, they are not. 1 millimeter is as good as 2 millimeter as 10 millimeter. So bigger is better is not a valid anymore. And it's time now for all to adopt the no NC on tumor as adequate safety margin. We all see patients like this. This is what used to see 20 years ago. Then the era of breast conservation started, but with some deformities. And this led to the appearance of the oncoplastic breast surgery, which was first described by Udrich. And it is was not invented to extend the unnecessary margins, but to remove the cancer without mutilations, reduce the re-excision rates, and to cope with unfavorable anatomy and the relative tumor size and location. Also to avoid the distortion and deformities after the conventional breast conservative surgery, and to lower the rate of mastectomies and the need for delayed reconstruction and reduction of the psychological morbidity. So the question now, is it one technique which fits all the patient? In our experience, when we started oncoplastic breast surgery, we used to, most of our cases, most of our patients have large breasts. So we used to use the inferior pedicle therapeutic mammoplasty and its modification to cover all the breast quadrants and locations, except for the tumors located at the 6 o'clock area. So we modify the pedicle to adopt and give and fill the tumor cavity after excision. And this is examples for these cases where we use, as we see here, the pedicle to fill the cavity. This is the one case. Another one. All these modifications were treated. We used to do until Krishna Kloff in 2010 published his famous paper about the quadrant per quadrant atlas in for oncoplastic breast surgery, and started we use different techniques for different quadrants. Maybe for the upper pool, we use the inferior pedicle therapeutic mammoplasty. For the upper outer quadrant, we use the lateral mammoplasty. For the lower outer quadrant, the J mammoplasty. And for lower quadrant tumors, use the superior and superior medial pedicles. And for the lower inner quadrant, we use the V mammoplasty. And for the upper inner quadrant, round block or the bat wing technique. As we all know, the main principle for oncoplastic breast surgery is proper wide local excision of the tumor, then proper defect closure. So this is the algorithm we are using now in our breast unit, and it is adopted from the Nottingham Breast Institute. In the large ptotic breast, we usually use the Wise pattern therapeutic mammoplasty, most of the cases, and maybe simple modified mammoplasty techniques we discussed. And in moderate and small ptotic breast, we use the vertical or the Wise pattern scar therapeutic mammoplasty. And if this not feasible, we use the volume replacement technique as well as what we do on the non-ptotic breast. So in lateral tumors, we use the LICAP flaps. In the central tumor, we use the TDAP and LD mini flaps. And for the medial tumors, we use the TDAP and the LD mini flap. And recently, we use the Aumental flap. So this is an example of how I start my operation. I usually use hydrodissection using saline with adrenaline in a concentration of 1 to 200,000 and lidocaine. Then we start to mark our new nipple areola to mobilize the nipple and areola for the new position. Then after this, we start to go for the wide local excision, which remove the tumor from the skin till the prepectoral fascia with a wide local excision. After removal of the lesion, you must remember to put your clips because this patient may need for a radiotherapy boost. So don't forget to put the clips. Then we start mobilization in the level of the prepectoral fascia in a way to facilitate approximation of the tissues. And by the end, we will find that this is a proper way of closure of the defect, giving a nice shape and a nice contour to the breast. And this, of course, will result in a good cosmetic result. This is the case I did. In our initial experience, patients usually ask for management of the diseased side of the breast, but didn't want to touch the normal breast. Now, after many cases of the patients, they ask for symmetry. This is another case of lateral radial incision, tumor located in the upper outer quadrant, and this is the post-operative picture. A patient with the upper inner quadrant using the batwing mammoplasty. And the other way to close the defect is to use the pedicles. As in this case, on inferior pedicle therapeutic mammoplasty, after wide local excision of the tumor, we use the inferior pedicle to cover and to fill the defect. So this will give, by the end of the result, is good shape and contour for the breast and without deformities. This is the case of the inferior pedicle therapeutic mammoplasty we see before, and this is the post-operative results. This is the case of vertical scar mammoplasty. It's the same concepts, the J mammoplasty, and this is the case of volume replacement using the thoracodorsal artery perforator flap. The patient had upper outer quadrant tumor, and we use thoracodorsal artery perforator flap. This is the perforator, and this is the flap after the utilization. And this is the post-operative results, giving good shape and contour, better cosmetic results. This is a case of lower inner quadrant in a cup C tumor with some microcalcification. So wide local excision was done, and the replacement was done with a momental flap, which we harvest with the laparoscopically. This is the flap, and this is the flap after fitting into the cavity, and this is the post-operative results. This case I always put in my presentation because I like it, because this patient has an old breast cancer in her left breast, was treated by traditional breast conservative surgery. As you see here, obvious scar with some deformity. The nipple areola shifted upwards. There is a change of the shape and contour and size of the breast. While in this patient was treated with the omental flap, with an inframammary incision, not visible tumor, maintaining the shape and the contour of the breast. So this is the past, and this is the present, and what we can do now. So the question: what are the contraindications for breast for oncoplastic breast surgery in 2020? As we all know, that age is not an absolute nor a relative contraindication for breast conserving surgery. Extensive or diffuse microcalcifications and the multicentricity are not absolute but are relative contraindication for breast conserving surgery. multifocality and being close to the nipple are not absolute and are not relative contraindication for breast conserving surgery. I want to mention that all these are patient-tailored surgery, meaning that it can be done in certain patients. This diagram shows 2 tumors located in the traditional excision area of an inferior pedicle therapeutic myoplasty. So why not to preserve the breast and go for an oncoplastic breast surgery like this patient with a large breast? All she had is a multicentric tumor located in the lower half. It's already will be excised in the case of superior medial inverted T therapeutic myoplasty. And this is the intraoperative, and this is the postoperative. I think this is an advantage of the patient, not going for a mastectomy just for multicentricity. Also, extensive vascular invasion and extensive intraductal component and the lobar carcinoma are not absolute nor a relative contraindication to breast conservative surgery. Also, positive family history and unfavorable biology are not contraindication to breast conservative surgery. Involved margin, even DCIS, and contraindication to breast irradiation are relative contraindication to breast conservative surgery. And BRCA1 and 2 are relative contraindications to breast conservative surgery. So now it is a patient-tailored surgery. And what is remaining now is that the inability to achieve adequate safety margin while keeping a normal-looking breast shape. This is the main contraindication for breast conservative surgery. And also the other thing is the patient preference. We should discuss all the issues with the patients in the form of the local recurrence and the incidence. Some patients were refused for this, and this is her choice. So if there is inability to achieve adequate safety margin while keeping a normal looking breast shape, what is your options? How can we deal with this? First, you can go for neoadjuvant therapy, or maybe for a skin sparing mastectomy or a nipple sparing mastectomy with an immediate autologous flap reconstruction, or now we are using the prepectoral implant reconstruction, or to give the patient the choice for choosing the modified radical mastectomy with or without delayed reconstruction. This is a case of nipple sparing mastectomy with LD reconstruction. As you see here, this is the preoperative, and this is the whole breast is removed and keeping the nipple areola complex. This is the post-operative after evacuation of the breast and the axilla, and this is the skin envelope, and this is the extended LD, and this is the scar of the LD, and this is the post-operative pictures giving good shape and contour of the breast. The question now, the other tool we have is the neoadjuvant therapy. And the question, why surgeons should use more neoadjuvant therapy? Actually, neoadjuvant therapy is very effective, and they can make locally advanced cancers operable. In larger operable cancers, neoadjuvant chemotherapy allows less surgery and more breast conservative surgery safely. Also, patients with HER2 overexpression and triple negative patients show survival benefit in case of complete pathological response after neoadjuvant chemotherapy, and also they can be integrated with oncoplastic breast surgery. And what should the surgeons to do now is to excise a big cancer just because you can. Because you should remember that the best oncoplastic breast surgery is to remove less, so the use of neoadjuvant therapy can reduce the need for sophisticated technique. And if patients are going to need adjuvant chemo or endocrine therapy anyway, then neoadjuvant therapy is an option. Like this patient is a 30 years old patient with a 20 millimeter tumor located as 12 o'clock cup B, and it is HER2 overexpression. So what we do? just wide local excision? Maybe, but this may result in some deformity because of the small size of the breast. Maybe we need some lipofilling. We can use a volume replacement technique. But of course, if we give neoadjuvant chemotherapy, then simple wide local excision can be done. This is the preoperative mammography. This is the post-neoadjuvant imaging. Just a small wide local excision, and pathology revealed no tumor residual. And this is the post-operative results. Excellent cosmetic outcome just because we removed less tissue. In a meta-analysis of neoadjuvant chemotherapy in operable breast cancer, there were 14 randomized controlled studies comparing neoadjuvant chemotherapy versus adjuvant chemotherapy, including 5,500 patients. There was no difference in overall survival except for those patients with triple negative breast cancer and patients with HER2 overexpression who achieved complete pathological response. Mastectomy rate was lower with neoadjuvant chemotherapy. There was also no significant increase in local recurrence after breast conservative surgery after neoadjuvant chemotherapy, and no increase in the rate of complications. The second issue we should think about in the surgery for breast is the surgery of the axilla. Although it is clear that the status of the axillary lymph nodes continues to be the most significant prognostic marker in the management of breast cancer patients, removal of lymph node carries no survival benefit. The purpose of axillary surgery in the context of breast cancer management is primarily for staging and local control. Through years, management of the axilla has tended to become incrementally less invasive. Historically, a complete axillary node dissection with removal of level 1 and 2 and 3 was standard. Now, if we are going to go for axillary node dissection, it's only level 1 and 2. Until Craig and Giuliano introduced the technique of sentinel lymph node into clinical practice for breast cancer, while initially considered as an investigational procedure, large validation studies have confirmed that sentinel node biopsy is a safe, reliable, minimally invasive procedure that accurately stages the axilla. We use sentinel lymph node in radiologically free and clinically free lymph nodes. Sentinel node biopsy has been validated in large cohort studies as well as the randomized controlled trials like the NSAPP, the P32 trial, which demonstrated that the false negative rate is low and that survival is no different for node negative patients who undergo sentinel node biopsy compared with axillary node dissection. Sentinel node biopsy is therefore a safe, accurate, and minimally invasive technique to stage the axilla in patients with breast cancer and should be considered the standard of care. This is a case of sentinel lymph node using the blue dye. This is the lymphatics taking the blue color. This is the blue lymph node. Now we are using both the gamma probe and the blue dye in detection of the sentinel lymph node, and this gives better results. The Dewar tracer technique is superior to use the blue dye or radioactive tracer alone in terms of sentinel node identification and false negative rates, and it's the technique of choice to identify the sentinel node. The subareolar injection technique has been found to be accurate in finding sentinel nodes, even in the setting of multifocal and multicentric breast cancer. In conclusion, oncoplastic breast surgery should be offered to breast cancer patients provided that adequate safety margins can be achieved. We should consider neoadjuvant chemotherapy alone or with oncoplastic breast surgery in selected patients. Sentinel lymph node in clinically and radiologically free patients is the standard of care. Oncological safety is the most important. We should choose the right patient and the right technique. And of course, this must go all for MDT approach.
Thank you, dear professor, for your splendid presentation. The history of surgical intervention for breast cancer have gone from radical and super radical mastectomies to organ conserve and reconstructive plastic surgeries. Your lecture was devoted to an extremely important medical and social topic, science, the breast being a symbol of femininity, and its removal has many negative influence on the physiological state of women. Thank you, Professor. The next speaker has two presentations dedicated to surgical treatment of metastatic breast cancer. His name is Danko Konstantinov. He is a clinical fellow in pseudomyxoma and peritoneal malignancy center, Bassington and North Hampshire, NHS Trust UK. The surgery of metastasis, by my opinion, is excited issue. Sometimes when the systematic treatment does not work, the surgical intervention can be the only path to salvation of the patient, increasing the length and quality of life. So, Dr. Konstantinov, now it's your turn.
Hello, everyone. Good morning. Hi from London, UK. I'm very happy that I'm presenting today. Thanks, Alisher, for kindly inviting me. And most importantly, I'm very happy that our long friendship turned into a good communication, and now I'm presenting on your conference. So as you said, I'm going to present two cases. So the first one is the breast cancer liver metastasis. So just briefly about the global cancer incidence, which was in 2018 and 2019, there are 18.1 million new cancer cases, with a death estimates about 9.6 million. So the cancer, as we all know, and oncology in general, is a very important and social important disease and factor. You can see the different distributions in between males and females, and most importantly, you can see the breast cancer that we're going to focus on today. Most importantly, the breast metastatic disease. So the breast cancer worldwide is the most common cancer in women in UK and USA altogether. One woman is diagnosed every 2.5 minutes, and there's one death every 6.5 minutes in Europe. More than 500,000 deaths worldwide are estimated every year only from breast cancer. 99% of the new cases of breast cancer are diagnosed in women, and 4 or 5 of the cases are in patients older than 50 years of age. 3 to 5% are in patients who have a positive gene for breast cancer, which my colleagues before quite clearly explained. So you can see the redistribution worldwide in between number of cases in every different countries. 1 in every 8 women in the United States will develop a breast cancer in their lifetime. So just briefly from the different stages of the breast cancer, starting from basically 0, which is abnormal cells, but clearly there is cancer cells noted, which will put as a stage 0, and going into the stage 4, which is the disease spread in the distant and the distant metastasis from the breast cancer. So you can see as early as we can detect the breast cancer, the better survival rate we can achieve. So basically, when we have the breast cancer in stage 0, the survival rate will be absolute 100%. And when we have it in stage 4, the survival rate is dropping significantly. This is the same diagram, which is a 5-year relative survival rate for breast cancer by stages. And when we're speaking about the metastatic breast cancer, it means that the cancer has already started spreading in the other parts of the body, which is mainly in the brain, in the lungs, in the liver, and in the bone. But it's not as simple when we're talking about oncology, because as you can see in the diagram, a cancer from one part can spread into many different parts. So oncology is like a very complex highway in which we need to know the different pathways and the back doors so we can treat it more appropriately and accurately. So as I need to speak about the liver metastatic disease, I need to go back to the topics. So the most common primary sites that can affect the liver, as you can see, it's first on the breast and then it's the colorectal and the GI origin. So when we go back in time, 30 years of age, all those images, when radiologists seen them and the oncologists seen them, it was completely said it's absolutely incurable, and it was like a lethal disease. So the patients have been said that they have a certain amount of time left, and they are absolutely without any other options available. Now, I think it's a very important that the medicine and everything is progressing, and one of the most significant importance in all that aspect is the specialized MDT. We all know that we are all participating in those MDT, and the most important bit in that MDT is the patients. As you can see, everything is circulating about him. So the specialized MDT that needs to have every center needs to have is related with the liver metastatic disease, in which you definitely need to have a dedicated liver surgeon who need to assess the hepatic resection and the assessment of the liver health prior to surgery, as well as the patient's availability to have that, where you can start from the age and different comorbidities. The medical oncologist needs definitely to be involved by choosing the timing and the specific aspect of the systemic therapy, the follow-up, and of course, all the new agents and the new clinical trials that are coming up needs to be also discussed into that aspect. Another thing that is, in my opinion, one of the also very important parts is the radiologist. Because when we're dealing with the liver metastatic disease, it's very important to have a really good GI liver radiologist who can evaluate the resectability of those liver mets, give you a very clear imaging where they're situated, to assess whether you can achieve a clear margin, which is the most important thing when you're dealing with the liver metastatic disease. And not at the last, you need to have a significant amount of healthy liver left so the patient can survive. Nowadays, what are the different treatment options that we're having ahead of us? Chemotherapy is one option. I'm not going into details because I know that my friend Alisha is going to go in further details about the chemotherapy. We have a liver-directed therapy, so-called, which are radiofrequency ablation, microwave ablation, cryoablation, chemoembolization, radioembolization, stereotactic body radiotherapy, hepatic artery infusion pump. Just briefly about all of them. So the radiofrequency ablation is inserting a probe under ultrasound guidance, whether the surgeon deploys an electrode with the machine that you can see on the right side of the corner, which deliver a radiofrequency energy, which will make a lot of heat around the tumor. And the idea is that after that procedure, the tumor will shrink, it will die, and all the tumor tissue will be replaced by scar tissue, which will be seen on the CT scan after that. So what are the main benefits of the radiofrequency ablation comparing to simple surgery? So there's a direct tumoricidal effect, there's a minimal side effects, it's less invasive than the surgery, it's less expensive than the surgery, and most importantly, it can be applicable for patients that are not suitable for big resections. Next one is a microwave ablation, which is very similar to the radiofrequency ablation, but it provides higher temperature, it's faster in heating, there's a shorter ablation times, there's a larger ablation in volume, and there's a less heat effect on the surrounding tissues, which means that it's not going to damage the healthy liver, but it's just going to damage the tumor. Cryoablation has a similar aspect, but the idea of the cryoablation is to insert a probe into the liver parenchyma under the ultrasound guided directly into the tumor, and a cold gas will start circulating into that area up to minus 190 degrees centigrade, which will make the tumors freeze, and the cancer is supposed to be dying with a certain amount of time, which will also go into making the tumor cells into a scar tissue. Chemoembolization, or so-called TACE procedure, is inserting a chemo agent through one of the main hepatic veins into the tumor, which specific microspheres will make the tumor bloodstream completely blocked, which will make the tumor necrosis and then die. It's a relatively new method, but it's quite well used not only for liver cancer, but also for like multiple liver metastases if they're situated in one part of the liver, so we can make that the other part of the liver expand and give sufficient liver volume after a potential resection. The next liver procedure that I can show is the radioembolization, which is also like a relatively new method. It's delivering specific microspheres of radioisotope 90Y directly to the tumor through the bloodstream, which will make a very much higher dose of radiation directed to the tumor comparing to the artificial radiation. And it's also give a lower dose radiation to the surrounding tissues, which means it's more safe for the patient. The stereotactic body radiotherapy is a really good method for treatment that delivers extremely precise and very intense dose of radiation, mainly affecting the cancer cells while minimizing the damage to the surrounding tissues, which is a really, really good option for patients that are unsuitable for any ablation or any surgical treatment. But the main disadvantage is that it's a highly specialized procedure, which needs a very dedicated high-volume trained center. The last option that I can discuss with you regarding direct liver procedures is a hepatic pump, which basically look like this device on the right-hand side. It's an artificial pump, which is basically as a size of a hockey puck. It's an old technique, but now it's been reinvented into the new era. It's designed to give a chemo at a constant rate to the liver, 24/7, which allows a higher dose of the chemotherapeutic agent to the liver, and exposure of normal cells from that chemotherapeutic agent is reduced. It's helped to limit the side effects from the chemotherapy, which all the oncologists knows they're happening quite a lot, and is also suitable for unresectable liver metastatic patients. Basically, that's how the pump looks like in real life. It's been implemented into one of the main vessels, and it gives a constant chemo agent flow directly into the tumor body. So what are the surgical options? As I'm a surgeon, most of the surgeons, we look ourselves like we're going to a gameplay when we're operating. So I'll just briefly mention the main potential operation that we can develop in the liver metastatic disease, starting with the wedge resections or metastasectomy for simple liver mets, continuing with segmentectomies, left or right hepatectomy, simultaneous or staged, like 2 or 3 stage procedures, depends on the complexity of the tumor, size of the metastasis, how many segments is affecting, whether it's affecting one of the main big vessels. It's very important preoperatively to maintain a good volume of healthy liver after the resection. So some of the procedures needs to be combined with some chemoembolization or ablation, and of course, like a multiple resections. It's very important when we're making a plan for any type of surgery on the liver metastatic disease to have a very good preoperative imaging. So most of our patients, when we're planning to operate on them, they need to have CT, chest, abdomen, and pelvis, liver MRI. Sometimes we need to use a duplex ultrasound, a PET scan. Sometimes another option is a hepatic angiography with a CT portal and venous phase. And it's also an option to use an intraoperative ultrasound, including a contrast with sulfur hexafluoroxide gas. It's very important when you're planning some patients after your MDT for surgery to know mainly the 5 factors that needs to be assessed clearly before you start any procedure. So first, you need to assess whether that patient is suitable to have an operation, because liver resections back in the time had a very, very high mortality rate and morbidity rate, but now with the new setting and new perioperative planning, the mortality rate drops significantly. You need to know the exact tumor location. You need to know whether there's any involvement of the lymph nodes and the number of metastatic disease. Clinical risk score is a new thing that has been implemented within the last few years, so I'm going to discuss that in details in a second. It's very important to the procedure to be as less bloody as possible, but sometimes it's not as clear. And of course, it's important to know whether you're making an anatomical or non-anatomical resections, depending on how many lymph nodes you're removing, and mainly where how many metastases are removing and where those metastases are positioned within the liver. And in the end, the final word comes to our pathologists. So they need to assess that we've achieved a clear resection margins after our resection of the liver mets. An acceptable resection margin is 0.1 millimeter from the tumor border. Clinical risk score is to achieve mainly how patients will behave and what will be the risk for him to have a big resection, if it's including like a left or right hemihepatectomy, and also to achieve what will be the potential recurrence rate within the liver after an operation. It includes, as I said, the age and the comorbidities that the patient has. We need to make a really good preoperative evaluation. We need to know whether there's any neoadjuvant treatment, mainly for the breast cancer, preoperative, perioperative radiation treatment. Sometimes we may need to do a diagnostic laparoscopy to assess whether the patient liver metastases are actually resectable when the perioperative imaging is not very clear. If we need to do any ablation or like TACE procedure or anything like that, we have different options. And also, it's very important to know whether that patient is involved in any clinical trials or not. On this diagram, you can see that the risk factors which are achieving the survival in for 5 years. So every point that have a lot of impact on the patient survival is like node positivity, disease-free survival, if it's less than 12 months from the primary of surgery, if the metastasis is like more than one, and the size, and carcinoembryonic antigen. So you can see in the past, if the patient has more than 4 liver metastases, it was considered a complete contraindication to any sort of liver surgery, which is not accepted anymore. But the survival rate is completely different for patients when they're having more than 4 metastases and between 1 and 3, as you can see on the 2 diagrams. So in conclusion, regarding the liver metastatic disease, first of all, breast cancer is very common and socially important disease. Screening programs and early detection is and can be life-saving and life-changing. Metastatic breast cancer needs complex treatment and options, and strongly individual. For every patient deserves better possible treatment. And finally, you need to have an availability to new trials and new treatment options that can be discussed in the patient's treatment plan. Most importantly, cancer treatment is a team play game. It's not for solo players. So you need to know that your MDT is your friend, so you need to have everything discussed there. So this is my next topic. It's the peritoneal metastatic disease after breast cancer. So first of all, I want to express my gratitude to my team. This is Basingstoke and North Hampshire Hospital. And on the right-hand side, this is the peritoneal malignancy team with Mr. Imran, Mr. Cecil, and Mr. Mohammed, which are the main 3 peritoneal malignancy surgeons. So peritoneal malignancy features, you can have a primary peritoneal malignancy, which can be resulted from a mesothelioma, a primary peritoneal carcinoma, mesothelial cyst, cystic lymphangioma, fibromatosis, or desmoplastic small round cell tumor. Or we can have a metastatic peritoneal malignancy, which are the most common bits, from which the appendix and the colorectal are on the first 2 places, followed by GI origin, ovarian, oral, and surprisingly for me, breast. When I'm saying about peritoneal malignancy, I'm mainly pointing at disease affecting the peritoneum with the spreads, which most of the cases looks like exactly like the picture on the right. The picture on the left is the main problem which is affecting the appendix. It's a mucosal of the appendix, which is the most common cause for peritoneal malignancy, in which case we're calling it as a pseudomyxoma peritonei. The treatment options when you're having a patient with peritoneal malignancies, which are rare conditions, and the main desirable treatment is surgery, which includes cytoreductive surgery, followed by the hypothermic intraperitoneal chemotherapy, so-called the HIPEC. CRS is being evaluated by the cytoreduction, which is going from complete cytoreduction or CC0 to major tumor debulking, which means that during the operation, for some reason, we cannot remove the tumor completely, and there is tumor deposits larger than 2.5 centimeters left anywhere inside patient's body. The main problem for not removing a tumor from the abdomen usually is affecting the small bowel mesentery, affecting the porta hepatis, affecting the liver, or affecting one of the big vessels in the retroperitoneum. The main HIPEC agents that we're using is usually mitomycin C, which is a very old and very effective agent, but there are centers worldwide that are using oxaliplatin, doxorubicin, and cisplatin, depending on the tumor biology. Treating peritoneal malignancies needs a very specialized and dedicated unit with full set of specialties. And we need a very dedicated MDT team, because most of those patients are very complex. They need a liver surgeon. Sometimes they need urologists, gynecologists. Sometimes we need to open even the chest, so we're using a thoracic surgeon. It's a very, very long, and the operating time is between 6 to 10 hours. I think the longest operation that I've been involved is 14.5 hours. The mean hospital stay, if it's absolutely without any problems, is between 10 to 14 days. And the disease-free survival and overall survival depends on the histology of the tumor and the completion of clearance. In preoperative setting, when we're planning a patient for a cytoreductive surgery in HIPEC, we always need to have the blood tests, including the carcinoembryologic antigen, tumor markers CA99 and CA125. We always need to have an up-to-date scan, including CT, chest, abdomen, and pelvis, sometimes MRI, sometimes PET scan. We definitely need to exclude any other source of a potential peritoneal malignancy underlying, so all the patients have full colonoscopy and OGD. All our patients have been discussed on our specialized MDT, and we're calculating the PCI score, which is a peritoneal index. I'll explain to you in a second. After we have a clear idea that the patients will go for cytoreductive surgery, we always have an OPD appointment with the patients and their family or relatives, because we need to explain the procedure in details, because most of our procedures have a higher mortality rate, change between 4 to 15%, which patients need to know in advance. Peritoneal cancer index is a score that we're using mostly related on the CT scan findings, which we're evaluating a number from 0 to 39. As you can see, these are the different quadrants of the belly, split it into 9 different quadrants, and also we are discussing the small bowel. In my opinion, the most important bit is the small bowel, because we can remove all the large bowel, but we cannot remove all the small bowel. So the higher PCI score, the poor prognosis is. But as I said, it all depends on the tumor biology. As I said, there is a breast cancer case that came into my mind when I was speaking with Alisher. So I tried to summarize the clinical case for you. So it was a 58-year-old lady with a breast carcinoma of the right breast, and the preoperative staging was T2N0. The operation was performed in a different hospital in 1998, so the data that I can collect from there was not very efficient. The patient was discussing their breast MDT, and there was a decision for surgical treatment, so the patients underwent a radical mastectomy axillary clearance. The final histology was T2N1M0. It was BRCA negative, and none of the receptors, all the receptors came back as positive. It was rediscussed at the MDT, and there was a decision for chemotherapy. So she was started on CMF regime, which includes cyclophosphamide, methotrexate, and 5-FU. 11 years later, surprising for the lady, she started noticing that her belly is getting bigger. She started gaining weight, and she's developing constipation with a palpable mass in her belly. She went to her GP, which sent a referral for a full colonoscopy and OGD, presumably that she's having a bowel problem. but all of them came back as normal. So the patient was referred for a CT chest, abdomen, and pelvis, which showed a massive ascites, 4-quadrant peritoneal disease, and bilateral Krukenberg tumors with omental caking. This is not the latest scan, but it's a similar presentation. But when I was checking, so it's a scan from one of our patients. So you can see on the top left corner, there is a huge amount of heart disease, which basically represents the pseudomyxoma. On the lower scan, you can see the liver, and all the liver is completely fused on top with tumor. The scan on the right-hand side is demonstrating the large amount of volume of tumor cells that you can see. So basically, this is how the peritoneal malignancy scans looks like in most of the cases. When I'm saying omental caking, this is the intraoperative findings from one of our patients. Basically, the omentum is becoming so fused from tumor cells, so it's become hard and enlarged. And as you can see on the right image, the transverse colon is completely inseparable from that omentum. So the patient was referred for an opinion regarding CRS and HIPEC to us, and we've discussed her on our SMDT, so there was a decision to proceed with surgical treatment. The patient underwent CRS and HIPEC, and we performed a total abdominal laparotomy, all quadrant peritonectomies, total abdominal hysterectomy with bilateral salpingo-oophorectomy, subtotal colectomy, antilostomy, lesser and greater omentectomy, and she had a HIPEC for 60 minutes with mitomycin C. Luckily for the patient, her post-op period was uneventful and she was discharged home on day 16. Surprisingly for us, the final histology confirmed metastatic breast carcinoma. So the MDT decision was to continue on the chemotherapy, and she started her chemotherapy in her local hospital. 10 years from then, the patient is still disease-free, survived, and her last scan was that I've found on our system was in 2019, and it was clear. So in conclusion, cytoreductive surgery in HIPEC is a complex procedure requiring specialized team with a broad spectrum of specialties available on site, but it can be an alternative and curative option for otherwise what is being discussed as an incurable disease. Peritoneal metastatic disease, we need to remember that it can manifest from a malignancy outside of the belly, which, as I said, was quite surprisingly for me. That lady has this breast cancer which manifests into peritoneal malignancy. Within the next few slides, I'm going to show you a little bit of the work that we're doing here in Basingstoke in the peritoneal malignancy setting. So this is our OmniTractor tractor. This is a new type of procedure that now we're doing here, which is like a laparoscopic HIPEC. We're doing that for a certain and very specialized cases where the PCI score is very low. It's mainly localized into the lateral peritoneum and the omentum. The 4 tubings are attached to the system, so I'll show you a brief video how it works. So as you can see here, this is an omentum with a few deposits inside. Okay, it was supposed to be a video. Let me just see what happened. There you go. So that was the same patient that we've operated. In my fingers in between are the big tumor deposits, but the omentum is not caked. And these are the 4 tubings for the HIPEC machine. So 2 of those tubings are putting the chemo agent in, 2 of the tubings are putting the fluid from the abdomen back through the machine. The idea of the machine is to put the chemo up to between 40 to 42 degrees centigrade, which is the most optimal temperature for tumor cells to be destroyed and the chemo agent to go into them. So this is the new generation of the machine. And there is another case which I'm finding quite fascinating. So that's probably one of the most extensive peritoneal diseases I've seen in my stay here in Basingstoke. As you can see, that lady's belly is huge. And the next video will show you basically what we found out inside her belly. So that's a lady who had what is called a pseudomyxoma peritonei. So she had a primary appendiceal tumor with very, very big Krukenberg's tumors. Let me just start the video. Okay, there he goes. We're always marking, as you can see on the belly, the spots for a potential stomas. So this is me and one of my consultants opening her belly. In that specific case, we're able to remove 14 liters of ascites. And I'm going to show you here in a second. This is one of the largest Krukenberg tumors I've seen. As you can see, it's massive. So it's basically the heartbeat on the right-hand side is the ovary, which is the right ovary, and everything else is the mucinous disease, which is producing the mucin. In procedures like that, it's very important to have a good amount of blood transfusions on a site because the neoangiogenesis that the tumor is affecting is quite extensive, and sometimes patients are losing a lot of blood. So we need to give them plenty of cryo and plenty of blood transfusions. So in the end, the main problem for that lady's belly was that small little appendix over there, which is basically make the whole redistribution into the peritoneal cavity, affecting the two ovaries to grow exponentially big. And that's all. So I presume if there's any questions, there will be later. Is that Alisher?
Thank you, Dr. Danko Konstantinov. It was a very interesting presentation. And now it will be my topic dedicated to the hormonal treatment of metastatic breast cancer. So before starting my talk, let me make a lyrical digression. The creation of the Soviet photojournalist Max Zakharovich Penson released in Pravda Vostoka Gazette, the Uzbek Madonna, which is revolutionary for its time, is a reflection of the purity of the motherhood. In 1938 was awarded the Grand Prix and the gold medal during the World Exhibition in Paris. The breast has always symbolized femininity and motherhood. Unfortunately, with the change in reproductive behavior and the westernization of the lifestyle, as well as the deterioration of the ecology, breast cancer is currently one of the complex clinical problems of oncology, especially when the tumor proceed is widespread. Before starting to analyze the topic, let me dwell a little on the structure of the breast. As you know, the breast is represented by glandular, fibrous, and adipose tissue, the ratio of which is constantly changing. At birth, the breast is represented by the rudiments of glandular tissue. With the onset of the menarche, the glandular tissue gradually begins to develop. The fibrous tissue in turn acts as a scaffold that supports the shape of the breast. The glandular tissue reaches its peak during the pregnancy and subsequent lactation. Approaching the menopausal period, the probability of getting pregnant and giving birth in a woman decreases, and therefore there is a restructuring of the breast. The volume of glandular tissue begins to decrease, being replaced by fibrous tissue. After menopause, the breast undergoes the fatty degeneration. This process can be traced on mammograms at different age periods. The high density of breast is associated with glandular and fibrous tissue, while with the onset of menopause, the transparency on the tissue increases significantly. Unfortunately, there is an upward trend in both morbidity and mortality from breast cancer in both developed and developing countries of the world. According to the World Health Organization, about 2 million new cases are detected annually in the world. At the same time, the number of deaths from breast cancer also continues to grow, and in 2018 amounting to more than 500,000 women. In the past, breast cancer was considered as a disease of nuns. As you know, in their service to God, They renounce everything worldly, taking various vows, including the vow of celibacy. This may be due to the fact that women are exposed to increased levels of estrogens for a long time, which in turn negatively affects the health of target organs such as mammary gland and endometrium, causing various kinds of proliferative changes. Other risk factors for breast cancer include those shown on this slide. There are early menarche or late onset of menopause, late first birth, and nulliparous women, age over 50, atypical tissue breast tissue hyperplasia on biopsy, family history of breast cancer, BRCA and BRCA2 gene mutation. Most of the above risk factors, according to recent studies, increase the risk of hormone-positive breast cancer. The risk factors for hormone-negative breast cancer are still unclear. Over the past 100 years, the concept of breast cancer treatment has changed. The role of surgical treatment in breast cancer has receded into the background. Surgical intervention from breast cancer have passed a difficult path from radical and super radical mastectomies to organ preserving and reconstructive plastic surgery. The hypothesis of linear progression of breast cancer by William Halsted, who concluded that the more radical and extended the operation was performed, the better its long-term results, had a great influence on the surgeons of the early 20th century. Supporters of the theory of aggressive local control performed super-radical extended interventions with the removal of not only regional lymph nodes but also supraclavicular, parasternal, and anterior mediastinal lymph nodes. However, the analysis of long-term results showed that such extended operation not only do not increase the survival rate, but also lead to disability and thereby a significant deterioration in the quality of life. Thanks to the research of the American scientist Bernard Fisher and the Italian oncologist Umberto Veronesi, it was proved that with the correct determination of the indications for breast surgery, the results of organ preserving treatment are no different from the results of treatment of radical mastectomies. And breast cancer itself is a systemic disease, the result of which are more depends on chemotherapy and hormone therapy. Currently, breast cancer treatment has many options, including surgery, radiation therapy, chemotherapy, hormone therapy, and target therapy, with the development of which in the past few decades, there has been a significant improvement in the results of breast cancer treatment. Breast cancer is a heterogeneous disease that includes malignant neoplasms of the breast with the different clinical courses, response to treatment, and prognosis. To date, there are 21 histological subtypes of breast cancer and 4 main subtypes based on the determination of receptors expression. Luminal type A, luminal type B, HER2 positive, and triple negative. The most common is hormone-sensitive breast cancer or luminal breast cancer, which according to the various authors is 65-75%. Hormone therapy for hormone-sensitive breast cancer has made it possible to increase relapse-free survival and overall survival among this category of patients. The father of hormone therapy for breast cancer is the British physician Sir George Thomas Beatson, who in his publication in 1896 described 3 cases of improvement treatment results after bilateral oophorectomy in the patients with inoperable breast cancer. The choice of hormone therapy methods depends on the hormonal status of the patient, whether she in premenopausal or postmenopausal period. Let me dwell a little on the mechanism of formation and regulation of female sex hormones depending on menstrual status. In women of the reproductive period, estrogens are produced by the ovaries while the regulation of their level in the body is controlled by hypothalamus through the release of gonadal-releasing hormone and the pituitary gland. Hormone therapy in this category of patients should be aimed at suppressing ovarian function, which can be achieved through chemical, radiation, and surgical castration. After menopause, the ovaries cease to function. So why does a woman not have masculinization symptom during this period? This is due to the existence of the aromatase inhibitor in adipose tissue. Due to the presence of aromatase, the pre-hormone formed in the adrenal glands is converted into the female sex hormone in the adipose tissue. In this connection, the use of aromatase inhibitor is recommended for postmenopausal patients with early breast cancer. Selective blockers such as tamoxifen can be used regardless of hormone status. We also need to have a clear understanding of what is menopause. Due to the ABC4, menopause is a condition after the bilateral oophorectomy, age older than 60, age under 60, and absent menstruation for 12 months or more, provided that the patient is not receiving chemotherapy, tamoxifen, or ovarian suppression, and the level of FSH and estradiol hormones in blood plasma correspond to postmenopausal values. With regard to early breast cancer, it can be said that oncologists have made significant improvement in the results of its diagnosis and treatment, which is not the case with advanced breast cancer. Despite the introduction of screening and modern diagnostic methods, even in developed countries, 30% of primary breast cancer patients have locally advanced or disseminated disease. More than 50% of patients with breast cancer develop disease progression at some stage of the disease. The results of treatment are also disappointing. The 5 years overall survival of patients with metastatic disease averages 25%. There are many options in hormone therapy for metastatic breast cancer, which allows the doctor to carry out an individual approach, as well as delay the moment when the entire arsenal of the fight against the oncological process has been exhausted. Hormone therapy is the main type of treatment for patients with hormone-sensitive metastatic breast cancer. You can notice that there is some difference in ABC4 and ABC5 recommendations. So now, even if the presence of visceral disease can be, unless there is a visceral crisis for premenopausal and perimenopausal women, the hormonal therapy also advised. And what about the visceral crisis? The visceral crisis is defined as a severe organ dysfunction as assessed by signs and symptoms, laboratory studies, and rapid progression of the disease. Visceral crisis is not the mere presence of visceral metastasis, but implies important organ compromise leading to a clinical indication for the most rapidly efficacious therapy. Examples, for example, liver visceral crisis is rapidly increasing bilirubin in the absence of biliary tract obstruction. So we also should know what is the primary endocrine resistance and secondary endocrine resistance. This is insensitivity to the effects of hormone therapy due to the presence of or development of mechanism to counteract it in the tumor cells. The primary endocrine resistance is defined as relapse, while on the first 2 years of adjuvant hormonal therapy or progression of disease within the first 6 months or of first line of hormonal therapy of advanced breast cancer. Secondary endocrine resistance is defined as a relapse, while on adjuvant hormonal therapy, but after the first 2 years, or relapse within 12 months of completing adjuvant hormonal therapy, or progression of the disease 6 months after initiating of hormonal therapy for advanced breast cancer. Resistance to hormone therapy developed in one third of women with breast cancer, and it is due to the loss of estrogen receptors, gene mutations, increased activity of HER2/neu, and loss of progesterone receptors, and also the dysregulation of mTOR pathway. Also, long-term hormone therapy can induce transcription of growth factor receptors, which leads to independence from the estrogen regulations pathway. Hormone therapy for luminal metastatic breast cancer, as well in early breast cancer, depends on the menstrual cycle, as well as whether the patient has previously received hormone therapy or no. Hormone therapy is used alone or in combination of two groups of drugs: aromatase inhibitor, tamoxifen, cyclin-dependent kinase inhibitors, and fulvestrant can be used as the first line of hormone therapy. It is interesting to note that fulvestrant is recommended both for patients who have previously received hormone therapy and for patients who have received hormone therapy for the first time. In patients with luminal type B and HER2 positive status who have not previously received target therapy with trastuzumab or pertuzumab, a combination of chemotherapy and therapy with trastuzumab and pertuzumab should be used as the first line, followed by a combination of target therapy with hormonal therapy. Patients for whom chemotherapy is contradicted for a long relapse-free period, minimal manifestation of metastatic disease, as well as a strong expression of estrogens and progesterones, hormone therapy in combination with anti-HER2/neu therapy is recommended. Possible options for hormonal therapy include luminal HER2/neu negative cancer is aromatase inhibitors plus inhibitors of cyclin-dependent kinase inhibitors, fulvestrant, and CDK4/6 inhibitors can be used. And fulvestrant plus PIK3 inhibitors, fulvestrant, and etc. can be used. It should be noted that the treatment of metastatic cancer is still difficult and requires a non-standard approach. With the development of fundamental science and new drugs, it will be possible to achieve good treatment results for this category of patients. Let me conclude our today's presentation with the word of the great French playwright Pierre Beaumarchais: to live is to fight, and to fight is to live. Fight to the end, and don't give up. Thank you for your attention. And now the next speaker is Dr. Rania Azmi, represents two countries, Kuwait and Egypt. She is a cancer patient advocate. So her topic title is Supporting Cancer Patients, the Complexity of the Journey from Prevention to Multidisciplinary Intervention for Critically Ill. She raised very difficult problem. Usually when the patient moves to the intensive care department, the role of oncologist and multidisciplinary team members goes down to zero. Only the intensive care specialist solves the destiny of patient. During our daily practice, we should not forget about the will and opinion of patient and his relatives, and do our best until the end struggling with this severe disease. So, Dr. Rania, you are welcome.
Thank you so much. I don't know if you can hear me very well, because I can adjust the mic. So, first of all, thank you for having me once again, and thanks for all whoever watch us right now. Bismillah ar-Rahman ar-Rahim. I'm going to take you in a journey into my presentation, and I'm very thrilled to be with Tashkent State Dental Institute, the Oncology Department, one more time. So thanks for the great organization so far. I will not be the one standing between you and your weekend because that's the last presentation. So I hope I'll have your undivided attention because we're going to be quick. And remember, you didn't have to travel to Tashkent. So you are in the comfort of your Zoom. But you yet has to fasten your seatbelt. Because I'm going to take you in a quick journey. We're going to talk about supporting cancer patients, the complexity of the journey from prevention to multidisciplinary interventions for critically ill. And you can imagine it's a very complex issue. I would like you to take a note of our Fadia Survive and Thrive in Instagram. If there's any question right now or later on, I monitor this account myself with other volunteers. So I would be happy to have extended discussions because I recognize that this will never be enough to discuss the issues of cancer support and advocacy. So do fasten your seatbelt because I'm going to take you in an interesting journey from three parts. First, I will introduce what patient support, what we do as patient advocates, and the complexity of cancer journey from a patient perspective. And then I'm going to focus on patient advocacy in prevention, focusing on prevention. That's the second point in pink. And in blue, you will find the patient advocacy focus on multidisciplinary for critically ill. You would recognize from this journey that there are many things along the journey, like the side effects, the quality of life, and other focus for us as patient advocates, other than prevention and supporting the critically ill. So, but that would be the focus, just to showcase the complexity and how all of us as cancer stakeholders, we need to broaden our mind and do coordinate and collaborate more, because that's how we can conquer cancer. This is an interesting analogy I usually give in cancer conferences as a patient advocate, because some of the circles don't recognize the role of patient advocate, and I'm going to discuss this in more details. But imagine if you have a lion and a rabbit running after each other, which one wins? Or which one more serious to run? The rabbit is running for his life, as opposed to the lion running for just another meal. It could be another meal. With all due respects to oncologists and patients, patients do run for their life. So it's really very personal. Now, I need to tell you that as Fadia Survive and Thrive, our skin is in the game, meaning that we understand patients inside out. The founder and the honorary president of the association, she's a metastatic patient herself. She was a metastatic patient. She passed away earlier this year. She's my mother. And she helped start everything and supported everything in this organization, knowing the suffers of the patients firsthand. And she suffered in the ICU as a critically ill patient in her last days for 43 days. So we really know what we are dealing with scientifically, emotionally, you name it. Now, I would like to focus a little bit on what it means to be an advocate. Well, the perception in some circles that we are a spy on oncologists, so they don't like us. Although we would save their time because we share evidence-based information with the patient that they will never have a time to share it with them in a more eloquent way, because there is limitation on their time in outpatient departments, and also in first diagnosis in primary cases and metastatic. There are zillions of questions, not millions of questions, and oncologists would feel, I empathize with them, would feel very bored to repeat them, and some of them do. With all honesty. And patients do think we are a spy also, because we talk very positively about oncologists, that we are spy working for the oncologist, and sometimes they are frustrated with the side effects of the medicine and the therapies, and we explain or bridge the gap between the two points of view if we talk about patient and oncologist, and also coordinate with others. So we are basically not a spy, just to make that clear. We raise awareness for the public, simplifying public information, scientific, and the ones from scientific conferences in a very simple language, practical to the public. We join scientific communities like Advocate in Science in the States to be updated on what matters for patients, like targeted therapies, new therapies, clinical trials, although it's not very relevant to the Middle East, and I'm going to talk about this in a minute. If I am too fast, it's your chance to focus and write notes to ask any questions. And again, you can reach us through the Instagram or other channels if you ask the organizers. We do publish and present abstracts and articles, evidence-based about our ideas and what we perceive to be a focus in our part of the world and internationally. And 3 years ago, the honorary president, before she passed away, she co-authored with me an abstract that was published in the Breast Cancer Journal as part of the ABC International Consensus Conference in Portugal. And last year we did publish another one, another paper regarding communications between oncologists and patients as a journey, not a destination. We do collaborate with policy-making circles like the European Commission, the Global Alliance, other sort of policymakers like FDA, to be closer to the circles where we can lobby for the interest and needs and wants of the patients. I did participate last year in a famous conference organized by The Economist on war and cancer, but I am now against the labeling of our fight against cancer as a war, and I'm going to tell you why, so stay tuned. As patient advocates, we have our convictions about oncology. So I appreciated all the presentations before me about surgery, about endocrine therapies, and all of that. At the end of the day, what matters for us is the quality of life. Your surgery, your treatment, anything that you do for the patient, if it not reflected in tangible quality of life for the patients, it would be unnecessary suffer. And we always challenge the scientific community about the use of overall survival and progression-free survivals as the main measurable endpoint in research. Really, quality of life matters, and because of the work of many of us, not only our group as a patient advocate, I think there has been some improvement in this regard, and they included something called patient-reported outcomes, and now it's measurable, so it's much related to this aspect. We do focus on the impact of the cancer therapies on the quality of life of patients in two main things: the adverse effects of the drugs and also the side effects. Not only the side effects, as basically the cancer therapies can be presenting, can be challenging. And also, let's recognize that a majority or a large number of cancer patients are elderly, having some comorbidities. So most probably they are taking somewhere between 10 to 20 drugs a day. These are chemicals entering the system, and there's no way to measure their interactions. And that's something that takes from the quality of life. So that's our focus as a patient advocate. Also, we recognize that targeted therapies, new drugs, even chemotherapy, which is classic, are tested in controlled clinical trials in certain profiles of patients that not necessarily would be reflected in terms of side effects and tolerability on all walks of life or all types of patients. So that's another challenge, especially in the Middle East, because we don't have our own clinical trials. So the issue is extremely complex. I did talk about the comorbidity. We really focus on that because we believe through our prevention campaigns that prevention is a key. And some of the things that go wrong in our lifestyles would be reflected in chronic diseases, diabetes, high blood pressure, heart diseases, and eventually cancer. So everything is connected if we're thinking about quantum theory. And think about this, just one tiny example. If someone diabetic and enters an ICU, guess how many times they will be tested for blood sugar? And it's very important. I'm not dismissing or discrediting that they shouldn't be measured that frequently, but it's every 2 hours. It means having this needle on the finger like 12 times a day. So that's one of the very tiny little pain that the patients have to go through when they reach. There was a new research in the era of COVID-19 talking about comorbid chronic diseases and acute organ injuries. So everything is connected, and I'm going to talk about this. So I told you to fasten your seatbelt because I really needed to have this as a quick introduction. And now I'm going just to shed the light why it's extremely complex. not only to address the cancer from your point of view as an oncologist or scientific community, also from our aspect as a patient advocate. Now, cancer has been goes back really an old history, like 3,000 years before history, at least found in an Egyptian papyrus. And yet, as we speak right now in 2020, 1 in 5 people will develop cancer before the age of 75. Isn't that a contradiction? Like, we know cancer for 3,000 years, and yet we didn't find a cure, and men reached the moon, but we still didn't find that. I think we are not choosing or we are not seeing clearly our enemy or our target. So I'm questioning now, and I did tell you this earlier, war in cancer, is it really a battle? I don't think it should be called a war because it implies that doctors and patients failed somehow in this war. They failed the war. They didn't win for a cure. And it implies if they fight hard enough or long enough, there will be a cure, which is not accurate. It's just deceiving because it's extremely complex disease, and it gets more complex and complex as a recurrence happens once and twice, and as the case advances. And this picture shows you an analogy, like a nice picture for a modern I call it cement forest. It's a very busy city, and the traffic light is the targeted therapy going into that system. Imagine that you have cars going onto the system of everyone else. So what would be the impact on this? So this is something to think about. It's not as easy or as simple as we think, and that's how patients get to the phases of being critically ill. So it's extremely complex issue. And when we talk about complex, I need to emphasize a little that even it's not a complexity in the modern world. Like in my profession, I do support decision making, and we have the sexy name of calling VOCA, which is volatility, uncertainty, complexity, and ambiguity. I did write an article early on in this pandemic talking about the new world order, and what's in it for you. I give an analogy here in the first sentence. The interconnection and complexity of human body is perhaps hundreds of times more of that of the complexity in our material world of economies and policies. So you can imagine, you see and you live in this pandemic, you see the reaction of policymakers, countries, and governments around the world about really teeny tiny something between living and dead, which is called COVID-19, right? Imagine the cancer coming. We recognize the complexity of the biology of our body, and this complexity is even more when cancer comes, and then you add more complexity when you intervene with various treatments, so be it surgery, chemotherapy, radiotherapy, or targeted therapy. So patient is extremely complex, and it gets more complex, and I'm going to focus on that. Now, complexity can be illustrated by just taking something that is standard or common for all countries, which is cancer control. The World Health Organization, and other ministries of health around the world adopt the cancer control policies and strategies, which basically is about 4 main pillars: prevention, and some of the slogans or the saying of the WHO organization: cancer is preventable and treatable. Leading infections of cancer are tobacco, alcohol, obesity, air pollution, and infections, right? And we're going to talk about prevention in more details, but I'm going to tell you that if you think about it, the first pillar is prevention. And the way it addressed is very theoretical so far, in my humble opinion as a patient advocate, and I'm going to tell you why. And that's one of the layers of complexity. Second is catching cancer earlier, or early detection. That's the second pillar of any cancer control around the world. And I think it has been sort of successful in many countries because it's measurable. Like, you can have a campaign of mammogram for 40,000 women and say like, okay, 10% of these 40,000 where we detected like really small cancers, so it's more treatable than catching them in earlier stage. So this has been very successful, but still complex because it's not accessible as for all countries and within the same country for all social classes. There are misconceptions and stigmatization, especially in this part of the world. Now, the third pillar is diagnosis and treatment. So if we cannot prevent, if we cannot detect early, for cancer control is an accurate, as much as possible, diagnosis and treatment. And these, the oncologist can talk about it, obviously, but here what WHO organization is claiming, cancer prevention and treatment, and here's the interesting part, prevention, as if prevention is already measurable, which in my humble opinion, again, it's not measurable, and that's why most of the policymakers are shying away from doing much for prevention. Cancer prevention and treatment services should be accessible and affordable for everyone. Treatment, I have my doubts. There are targeted therapies that cost a couple of thousands of US dollars a month, and it's really not accessible. And we can argue the cost-benefit analysis that it's very expensive and it has huge side effects at the same time. So maybe the older edition of the therapies are better. Lastly is the palliative care. And this is a huge pillar of cancer control. Much has been done, but as a patient advocate, as a patient point of view, I don't think we are again targeting the main purpose of palliative care. It's not about having extra drugs to alleviate pain. It's really more than that. Pain management is a completely articulate discipline on its own. I'm watching the time. I'm just highlighting this, and stay tuned and still fasten your seatbelt. Like we have 2 points to go, and it will be quicker than this. So the WHO organization, again, having the statistics, about 66% of patients who have advanced metastatic or terminal cancer suffer from pain, and pain is unpleasant sensory and emotional experience that should be relieved to improve the quality of life. Again, these are nicely articulate, written policy making statements. I was part of that maybe 9 years ago, convening somewhere nice in a nice hotel in Bethesda in the States to draft something that will be published in The Economist or in these fancy organizations like the WHO organization. And I figured out we are not close to the patients. We are not seeing real time what's happening. I'm not discrediting the information. Sorry? Okay, that's just like an intervention. These are real issues. And for us, the token is it's easy to get thousands of prescriptions, especially for pain management, but it's really very hard to get one single remedy. And that's what we need to think about. So enough about the complexity of the whole journey. Let's focus now on prevention, and then I'll focus about critically ill in the remaining time. I'm not sure what is the remaining time, but it's I think I still have 10 minutes, so I'll divide 5 and 5 for each. Prevention is million times more important than a cure because we cannot guarantee a cure, at least in cancer. And there's a famous research convened by WHO organization with hundreds of researchers that find out that cancer is a preventable disease, at least in adult cancer. Children with cancer is a completely different story that requires major lifestyle changes. And I'm getting this diagram from that research, like in the green pie chart, saying that 90 to 95%, if you're following with me, it's environmental factors, as opposed to less than 5 or 10% genetically driven causes for cancer. And that has been well studied and evidence-based. It's not like an argumentable or disputable fact. Environmental factor could be like the tobacco, diet, infections, obesity, alcohol, and other factors related to air pollution. I'm going to talk about this in a moment. It was not a surprise that the Times magazine in one of the years featured their cover by saying, why your DNA isn't your destiny. And I did many campaigns here having the same catchy headline. And in the very small letters underneath, it says, the new science of epigenetics. So we do know scientists has been historically tell us about our genes and how we inherit the colors of the eyes, the height, the size of your shoes are genetics. It's never going to change after you got born, right? But there is a new, relatively new science, which is epigenetics, and it basically tells that or shows that many of the non-inherited environmental factors and experiences have the power to chemically mark the genes that we already have and control their functions. And marking these genes is capable of switching on and off these genes based on these environmental factors. And we were going to discuss what environmental factors in very briefly. But it's enough to say that we do have the genes that are against or protecting us from diseases, and we have genes that promoting diseases. And it's on our hand as much as possible through our lifestyle to switch on and off such genes. So think about it as if you are reading a book and you marking that book read or ignore. It's the same thing with your lifestyle. And these factors, which called epigenetics, is related to exercising, nutrition, how clean is your air, how is your emotional health, all this promoting anti-inflammatory and antioxidant and anti-mutation sort of environment, which is very healthy. And the classic thing to say is just go for colors in fresh veggies and fruits because they are full of phytonutrients and they are chemicals that really very beneficial to us. And as well as the chlorophyll, which is the blood of the plant. So if we eat it fresh, we can get these chemicals. And the token is to consume as much as possible, like the majority of your diet, as opposed to eating one green leafy something and the rest is just junk food and say we are doing great. So this is where the complexity comes. We recognize that there are genetics and there are environmental factors, but we don't understand as a public, and I'm now appealing to the public, not to the scientific community, which we basically part of the public, that some of the things we do, like the polluted air or smoking or our metabolism of some food that we consume can damage the DNA and have what is called free radicals, which steals from the healthy cells. And antioxidant has been hugely promoted. Everyone knows about it in the public, but they don't know about free radicals. And antioxidants, the one like the vitamin C is like pouring 1 cup of water into a sea. It wouldn't work. It needs more than that. It needs lifestyle change. So talking about environmental factors, there are specific external environmental factor like physical activity and diet and water that you consume a day. There are general external environmental factor like the social capital, the urban, the climate, the green spaces, and then even what inside us, it's called environmental factor, but it's internal environment like the metabolomics and proteomics. It's like a combination between how you metabolize some of the things and how healthy is your microbe inside your intestine. So these assess the health of risk, and I have to tell very quickly from a scientific point of view that what confuses the public. When we say eat more nutrition, de-stress, sleep well, don't smoke, all these sort of things, they always have an example that counters that. Like I have 90 years old who smokes and someone who is 40 years old, never smoked in their life, but they got cancer and died from lung cancer. Why this happens? Because these factors are not deterministic. They are stochastic, the way they say it in statistical circles. And you can think about it, from the day you were born until your adulthood, you are exposed to many things, and that's the idea of what is called exposum. It's the collectivity of risk factors and healthy factors that you get exposed of collectively that determines if you ultimately will be protected from diseases or prone into diseases. And everyone is different. There is no such thing that we are all the same. Like if I eat dark chocolate, it's the same chemicals is not the same impact on me as opposed to someone else. If I smoke, it's not the same. So we cannot just by observation recognize that these are serious risk factors we are conditioned as a society to believe in things when we see it, and we cannot believe everything we see. I hope I didn't get into much details, but that to show you it's prevention is not that measurable and it's not that simple. Even if you tell the truth to the public, it's not easy to change their lifestyle, all of us included. If I focus a little bit on the critically ill and how multidisciplinary matters, one of the very famous international ICU journals, very respected internationally, talked about many issues in the cancer. And they did admit in a recent edition a very important fact. I'm going to read it for you. For many years, ICUs have focused on the treatment of acute illness and neglected the emotional side of patients and families. This is most evident in cancer patients. We must humanize ICUs, make them open to family members, minimize noise, and integrate into our work teams, respect the rhythm of patients, and make environment less inhospitable and more hospitable. There are much more than this. We recognize that there are guidelines, and again, everyone is doing their best in their own specialty. So this is not a hot potato game to say who's accused of not doing their best. It just, we need to see the bigger picture, why we are all here. Multidisciplinary team, mostly medical team. In other ambition, as a patient advocate, we would have loved to have recommended more team because it can help in critically ill patients. And I needed to show this diagram that really throughout the patient journey, there are many multidisciplinary teams involved by necessity, and they change over the course of the disease progression. Again, I'm not questioning the jurisdiction or how serious everyone in their profession, but what multidisciplinary team mean for us as patient advocate. Let me just highlight this fact. This issue is extremely complex because if a patient gets to reach the phase of critically ill, it means that either of two reasons. The cancer has progressed beyond the point that can be controlled. Okay. And equally important, the immune suppression is very real, and it makes the body of the patient interact in a way that is, again, unmeasurable, unpredictable for drugs and for any other intervention in the ICU setting specifically. And let's recognize that ICU patients are very time dependable. Time means everything in intervening. It can be a distinct fine line between life and death. And also, to make the picture more complex, we recognize that reaching that point, it means multi-organ failure, and there is no way to reverse that. And I'm going to talk about this very briefly at the end. And this is the part where we can intervene as patient advocate, as in a community, as a specialist intensivist at the ICU, an oncologist. Some of the treatment and in the ICU really through sedation or through invasive mechanical ventilation can cause these multi-organ failures. To get the picture more complex, aside from multi-organ failures, aside from cancer, it has been proven that also organ crosstalk in shock and critical illness. Meaning, this is one example, acute lung injury and acute kidney injury, just like they crosstalk, they impact each other in illness. So it's not about being very focused on multidisciplinary team, bringing someone who is specialized in kidney diseases and someone specialized in lung diseases to get their advice. It's more complex than that. It needs really more intervention. And let's recognize one more time that every patient is different. No one solution fits all. We need to pay attention to that. And just to summarize about the multidisciplinary in critically ill, what our focus would be going forward and has been in our minds as patient advocate and as Fadia Survive and Thrive. And I promise I'll conclude in about 3 minutes. So be ready with your questions for all presenters and also for myself. Multidisciplinary would mean two things. You have to keep in mind the prognosis. We are doing multidisciplinary not as a checklist, not to protect the patient, not to protect the doctors, we really need to have a good prognosis, and that will never happen unless we consider multifactorial factors. So these are the things I need to highlight. Managing conflicting demands of multi-organ support is the basic of modern critical care. And this is no-brainer, yes, but let's recognize the second point. Look at this. Have a thorough read with me. Even if ICU admission for cancer patient was only to support a single organ system, there is almost always a potential for dysfunction of other organ systems. And pay attention, why is that? Well, either directly due to the primary disease. Okay, we know that cancer can cause this, but remember, there is a saying that most of the cancer death happens because of complications, not from cancer itself. And as I started the journey of cancer advocacy 8 years ago, I never knew what that means. So it's in B here, in the second point, or indirectly from distant effects of primary organ failure. We talked about crosstalks, right? Or of organ support therapies, such as sedation or invasive mechanical ventilators or ventilation. So the therapies themselves can reach or push the patient to the end of life. And I'm not saying that ICU are not lifesavers, but we really need to recognize the holistic view. Why we are doing this intervention, for what? To extend the lives while the patient is suffering, or should we take the life support? It's not about taking the life support at this point, and I'm going to talk about this in less than a minute after the third point. The improvement in prognosis of cancer patients in ICU is multifactorial. So the knowledge of these factors will be fundamental to patient management, and more importantly, it would be the challenge for any future improvement. So the final words is, I didn't even address the issue of side effects, but the statistics say 1 in 3 patients really wanted to know about the side effects before getting the treatment, and that's improving. I have to say with all honesty, in the last 8 years, if I compare what was known and what wasn't about side effects, like many of them are known, but it's still very critical to be addressed, because again, in advanced cases with more complexity, some side effects can be confused with extremely life-threatening problems like sepsis. There is a huge side effects of targeted therapies and chemotherapy, which is diarrhea, but sepsis also causes diarrhea. How to distinguish between them, how to build the awareness. Who would build that awareness? Would it patient, advocate, oncologist, the community? That's a shared responsibility. And we know the steps of sepsis can be life-threatening, and it's really all a matter of time and awareness. So I'm emphasizing this Sepsis Alliance time guidelines about how to be aware about temperature, infection, mental decline, and severe pain or shortness of breath that can be not an early sign of sepsis, but something that would tell you intervene immediately. There's no time to waste in having multidisciplinary team checking in a span of a week what's happening with the patients, while you could have saved the life accurately addressing that. So that concludes what I have to say. These are the 3 things I needed to highlight to get you in the journey of complexity. I hope you enjoyed it, and I would conclude with this picture from the Little Prince story. My drawing was not a picture of a hat, it's rather a snake that swallowed an elephant. So we really need to have a broader mind to see the real problem here. And remember, we cannot fix a problem that we don't see. Thank you so much for listening. And remember our Instagram account if you need to reach out after this. And I'm very open for any questions. Thank you. Rahmat.
So thank you, dear Rania, for your excellent presentation. I can say that the patient advocate like a conscience of the medical system, and during our daily practice we always forget about that we do not treat the disease, but we treating the patient. So not only the medical issues should be solved, but also the social, financial, and legal one. So I think it is very pity in developing countries the patient advocacy is not so developed, but I hope we will do it in the future. And the main thing is that doctors and patient advocates should work together to try to do their best. So thank you. Now we will move to the questions from the audience. Is there any questions? In our chat there was not so much questions, only the opinions and expressions. But is there a
Give them some time. I know these are very complex issues for the general public and also for the scientists if it's outside their field. So,
and I think
I hope they will not be shy.
All the audience is very shy people. That's why we're just waiting for the questions. No questions, so we can move to the discussion. If someone can tell something about today's event from the speakers. Dr. Rania?
What would you like me to say? Like comment on the conference in general? Or
in general, you can discuss with the another speakers, or you can express your own opinion about today's conference. I hope to continue this kind of conference in the future as well. So.
Me too. Well, first and foremost, thank you so much for organizing this, you and your team, Dr. Jamila, and I know many behind the scene preparation. It wasn't an easy things, and I'm very pleased to take part of it. Excellent work compared to other conferences that was tried or organized during the pandemic, during this COVID-19. Thank you for this. My comment is, I think you did a great job in having different speakers representing different perspectives about cancer. It was truly a multidisciplinary from surgery to intervention with endocrine or other sort of treatments, and I'm very thrilled that you have the patient advocate also sort of intervention represented by our association. I think it's important, and before the pandemic there have been a few initiatives for that. Like there is an increase in involving patients. They are not perceived as a spy anymore, as I said, and also they are not perceived as someone who is totally outside the field. There are many training and many research certification that happens that try to get us to the basic knowledge of basic science, even translational science, to be able to understand where the medical community coming from. I would be very curious to know how the other colleagues or other speakers today think about our patient advocate perspective, because I oftentimes, and you were one of them, Dr. Alishar, when we met in Portugal a few years ago, when we say we need that, like we need to reduce the side effects, we need patients need this, patient need that, and then you, as an oncologist, said like there are limitations in my time, there is limitation of what I can do. So what do you perceive, like if we can brainstorm for like 1 minute, what do you see reasonable going forward? I recognize that we will not solve all the world problem and all the patient's problem in these couple of minutes, but it's just something if you feel comfortable sharing as an oncologist.
Only mine opinion, or you would like to hear?
Everyone,
please switch
everyone
on
spoke today.
all the speakers. You can switch on your cameras so we can have some little discussion about this issue.
I think all the MDT, the purpose of this is to reach the cure for the patient. But if we think about how is the quality of life, this is a different main issue. So sometimes we search for cure, but we shouldn't ignore the quality of life of patient. And this is what happened exactly in respect to surgery. So many patients and recent studies demonstrate that the psychological impact of the patient and the patient undergoing breast conservative or oncoplastic breast surgery show better results as regard the cure rate of it. So I agree with you that patient advocacy is something we should consider in our MDT.
Okay, that's very valid point. The quality of life, the psychological part do matter a lot. We just don't measure it. It's not measurable, so that's why we perhaps shying from involving psychotherapists in critically ill phases and also early on.
I have a question for Dr. Danko. So I was asking about, we are using mitomycin C in cases of, in our cases of HIPEC.
Yeah.
But you mentioned oxaliplatin, and some authors are recommending oxaliplatin, but we don't show good results in our series. I don't know what's your experience as regard the use of oxaliplatin in HIPEC.
So basically, in Basingstoke, we're using mitomycin C. They've never tried to use oxaliplatin because there's first of all, there's no dedicated benefit of it. I know that there's a few Japanese and Korean centers that are using oxaliplatin, and they're making a trial to see whether there's any further benefit or not. In UK, the NHS system is slightly more complicated, than to approve oxaliplatin in the area of CRS and HIPEC. It needs to have at least a level 2 evidence that it's maybe not better, but at least as good as the mitomycin C, because the cost effectiveness is very important in those cases, and at least we know what the potential outcomes and the risk factors associated with mitomycin C is. So my consultants have tried oxaliplatin for a few cases. They've noted that it increased the intraoperative bleeding dramatically, and that's why they've stopped it. I just make a point that except for the mitomycin C, you can also use oxaliplatin, doxorubicin, or cisplatin, depends on the tumor biology. So for example, if you're doing a cytoreductive surgery for mesothelioma, like epithelioid mesothelioma or malignant mesothelioma, we're usually using doxorubicin and cisplatin instead of the mitomycin, because the mitomycin won't work.
Okay.
So Rania, it's a really nice presentation that you've made. I think personally for me, the patient advocacy is very important. So to share my personal experience here in Basingstoke, in our MDT, we have a dedicated psychologist. So every patients have been assessed preoperatively, and there's the 3 different grades, like the green, the amber, and the red. So the week before the patient came for an operation, we know in advance who that patient is, who are his relatives, and whether he is green, amber, or red. How does that patient wants to be assessed? Sometimes, for example, if his name is William, he wants to be called Bill or something like that. What percentage of the disease and the progression and the outcome he wants to know, because as you said, right, a lot of patients cannot accept the whole information. They don't want to know, or they're going to neglect it and things like that.
Yes.
And I think that's very important. And I think, as I said, in the center of our MDT aspect is the patient and his outcome. So the quality of life is the most important thing. And another bit is, I've seen that there's a lot of blood sugar checks in ITU, but now there's a lot of companies that are producing, those blood sugar devices that are measuring the blood sugar in the sweating. So there's no needles, and there's,
less invasive.
Yeah, You can even put it on your as an app on your phone. So basically, you can check your blood sugar at any time without any problem.
That's interesting. I hope it would be in the guidelines soon and be as accurate, because it's really unnecessary pain. Every relief of even tiny pain, it would matter. And if I can just comment on what you said, and some patients don't want to know.
Yeah.
This is very real, and I thank you for bringing this to the attention of now in the conference, because some patients, and I don't like to stigmatize that this is in Middle East, because I have seen other patients also around the world in the forums of patient advocates in the States and in Europe. Some of them, their personality, they have the uncertainty, especially metastatic patients. They have the uncertainty that the disease is back. But when they know for fact, like if they see the MRI or the CT scan or the PET scans, or hear from the caregiver or from the doctor that the cancer is back, it just would be, I don't like to exaggerate, but it's like as a green light, go to die. That's how they perceive it. They shut down. They don't speak to and I have observed that they don't speak to their families. It came back for the second or third time. That's it. They, as opposed to knowing little information, that what you need for them to do, like eating a little bit healthier or exercising or walking. That's what they need to know, without knowing the details that it came back, or not to hide. There is a delicate balance, I have to say. Yeah. Between different personalities, and it's and it's huge as far as the quality of life. Some patients told me I remember her very clearly. She's from the States, African American. I told her, you need to speak up. Like she said, like, I am not that person that speaks up in my own personal life, and this would not change as when I became a patient. This something I remember over years, that that's why I emphasize over and over that every patient is different. Their personality, their immune system, the way they interact with food or information, it's just unbelievably unique to everyone.
Yeah, absolutely agree. Yeah.
We can close our ceremony. It was very exciting, and you should always we will always attract you to the future events, and I think it is very important conference for our students and our teachers and colleagues. There was a lot of participants from all over the world, from Canada, USA, Egypt, Kuwait, Kazakhstan, Uzbekistan, India, Pakistan, etc. So I hope to see you in the future on the same platform.
And if just I can comment, Dr. Alishar, if there is a way for the audience to, if they request, I know that you will provide certificate of attendance for the ones participated, but if they ask about my contact details, by all means, do share it with them. And if you can check one more time about the questions, it's very important to have two-way communication. We learn a lot from our constituents.
So we sent yesterday. We sent to all the registered participants the email about the event, and they will receive the certificates of attendance soon. And we can communicate. And if every participant agreed to share their emails, we can make some group, and we can share the presentations and the expressions about this event, and maybe someone would like to see something different. I mean, to organize some different topic.
Okay.
Okay, we can close today's conference. Thanks to everybody. Goodbye.